Welcome everybody, and thank you so much for taking the time today to attend this webinar where we would like to share you the 3-year clinical experience with our new matrix implant system. My name is Sandro Venanzoni. I'm originally a mechanical engineer. I went into implant dentistry 15 years ago when I joined Straumann, and now for 10 years I've been the Chief Technology Officer of TRI. So what is actually the background of this novel matrix implant? I'm sitting here in Zurich at the university in the office of Professor Ronald Jung, and many years ago we had a discussion and we realized that there is a new world, and the new world is about implant prosthetics with all the new technologies. So we have scanners, we have design software, we have milling machine, we have printers, we have all these novel materials, but we're still facing the old world, and this is the implants, and especially the implant connections. They were developed 30 to 40 years ago when nobody knew about all these new technologies. That's why we really found this mismatch between the old world and the new world. And this is the reason why today we still have to use abutments and tie bases to restore implant. And this was for us the reason to develop the matrix implant, that is the world's first dental implant that is specifically designed for the digital workflow. So with the matrix implant, we will show you how you can restore your implants directly from your 3D printer or milling machine without having to use any abutment or cement, without any limitations. So today is a very special day because 3 years ago, a group of experts started to place the first matrix implants into patients. Then 1 year later, we had an amazing event in 2021 in Zurich, where these experts shared their 1-year clinical experience with the world. And now it's 2 years after the special event, and our expert can look back now to 3 years of clinical experience with the matrix implant system. So not only the number of matrix users has grown tremendously all around the world, but we have also established a big amount of additional preclinical and clinical data on the matrix system. For instance, this study, the PMCF study, that shows a great 99.7% success rate after 2.5 years. But we also have additional studies, and I'm looking forward that our experts are going to show these studies with us in their presentations. What is to me actually most exciting is that we didn't stop the innovation 3 years ago when we placed the world's first matrix implant. We have even accelerated the innovation cycle by creating this digital ecosystem of applications around the matrix implants. For instance, we have introduced the scan and smile technology that allows to print directly a provisional restoration of the implant, or the digital healing color library, or the scan bridge that allows us to scan full arches in a fast and predictable way, or the TRX guided surgery. So I'm very much looking forward to Dr. Marco Zeltner's presentation, where he will share this case that we treated together. It's a very complex case, and it really shows how all these digital applications actually are coming together and make a full digital treatment of such a patient in one day, in a few hours possible. Some rules for the webinar. So in Zoom, you have a Q&A field. If you have any questions, just type in your questions and we will try to reply to them. If you want to contact with us, send an email at matrix@tri-implants.swiss. Or also a great opportunity is the EAO conference next week in Berlin, where we will be all present from the TRI team. I really would like to say a big thank you to all the matrix experts who have trusted us, who have placed the world's first matrix implant. And it's amazing that the same experts are in this call here today, coming together again. But now I would like to give the stage to Professor Ronald Jung. He's trained in prosthodontics, implant therapy, and surgery. He's the chairman and clinic director of the Clinic of Reconstructive Dentistry at the Center of Dental Medicine here in Zurich, and among several other positions, he's a member of the Osteology Board of Directors and serves currently as the EAO president. So I'm sure he's very busy because next week is a big meeting in Berlin. And this was the moment, Ronnie, when I left the stage to you at the Matrix Special event I think you look here very excited, and I really hope that you're as excited today after using the Matrix implants for 3 years. Thanks again to all of you, and Ronnie, the stage is yours.
Thank you very much, Sandro, for that very energetic introduction. And I think you're totally right. I think we haven't lost any of our excitement for the Matrix. And I'm really very happy to have everybody here. And today is really kind of a special day because we do celebrate, in a way, the happy birthday of our Matrix implant. And it's an early birthday, but still, I think it's an important birthday. We celebrate today the third year of the Matrix. Personally, I think we have experienced a lot within the 3 years. And as Sandra said, I think it was just not 3 years of placing an implant. It was 3 years of an excitement, 3 years of trying to better understand, and also 3 years of innovations. And with every year we gain more knowledge about the implant and its opportunities and its limitations. So we started, especially went 3 years ago, by saying this is a new area of personalized dentistry, of a digital area of digital dentistry, which we had not seen before. And I think that has been kept, this excitement has been kept throughout the 3 years. Now, before introducing you guys, I would like to have a quick review to what I did when I had my first implant, which I presented at this really amazing event. I remember very well, it was really a very good event under difficult circumstances during this COVID time period, where it was really, they were limited. We had to be sit apart from each other. So it was really kind of a difficult scenario, but I think we managed this in a very nice way. Now, at that very event, I presented my first Matrix implant, and I still love the story about that. So it was actually a time where a patient came for just a lower molar, and it should have been done by one of our postgrad students, a simple case. And this postgrad student was COVID positive, so she couldn't come for the surgery. And then I was supposed to do the surgery, and then I was totally bored just doing this lower right molar. I called Sandra and said, "Listen, bring me this new implant. I want to do it." And that's how I did it. So I never used any description, brochure, or whatever. I just placed the implant. I think we are all used to do this implant. That was not the fun part. But what really changed my mind was the way we could really provide the patient within 30 minutes a provisional trial. In a way, I remember very well, we started with immediate loading in 2002 with Roland Clausen here at the University of Zurich, which were kind of pioneers. And it was a nightmare to do immediate provisionalization at that time point. And now, all of a sudden, we have a tool available which helps us without any need of any impression, with any need of any further manipulation at the patient, to provide the patient within an hour. Here it was a milled crown at that time point. Today we do more the 3D printed crown. So this was for me really mind-breaking. And this was at the end then the Matrix implant there in place. Immediately after final restoration, we can see here then the PMA crown, which is on top there, screw retained. This is how the PMA crown looks like. Also, our lab, they never had any kind of diagnostics done with this patient. So we all have seen the patient for the first time. They just mirrored the contralateral tooth in order to mill this lower molar. And this is how I let the patient go. And this is then the situation 3 months later, when we changed the temporary reconstruction to final reconstruction, again, with no need for additional scan. Basically, the patient comes in like changing wheels at your car, just coming in, getting the temporary reconstruction out, and then screwing in here the final reconstruction, the zirconia reconstruction. So this was really, for me, a complete breakthrough in terms of modern, personalized digital dentistry on dental implants. This was the crown, how it was fabricated by Andrea Patrizzi, our chief dental technician. This was the situation 8 months later. and I could recall the patient now 2 weeks ago for now the 3.5-year result after loading. This is how the crown looks like from the clinical situation, very healthy soft tissue conditions there. Here the occlusal view of that crown, and the one where everybody's interested in is looking at the 3.5-year result from the X-ray point of view. And I have to say, this is how I really love seeing X-rays after a time period, which I think compare that is X-ray to the 8-month result, we can see either a maturation also of the bone margin over this time period. And again, this has been for me an intervention placing an implant. Then the scan has been done by one of our assistants. I just screwed in the reconstruction and that's it. So this is for me really where modern dentistry should go to. This is a simple case to kick off, and now I'm very happy and thrilled to start now the presentations by our top experts. We start with Alessandro Ionescu. He has been graduated from the University of Bucharest in 2001. He's the co-founder of Quintessence International in Romania, and he operates on the Aesthetic One Dental Clinic in Bucharest. And he was really also among these top experts, starting with the matrix implant. And Alessandro, we are very excited and looking forward to your presentation.
Thank you very much. Thank you for the introduction and all this reminding of our time 3 years ago, which was actually a very good time. I would like to thank my family, my team for all this time that they allow me to do my dentistry passion, and also to TRI and yourself for gathering us for this reunion today. So where did we start? We started here, back in Sandro's office, more than 3 years ago, and I had this toy in my hand, and I was very keen to see it working in real life. And we were discussing at that time, as I was very passionate on using exclusively tissue-level implants, how can we go from a golden standard that we had with a cemented crown directly on the implant neck to something that will connect also directly to the implant without any other intermediate titanium basis or cement or anything else. So this should have been the new golden standard of this. Of course, we were very excited and happy, and we didn't know so many things that are going to find out in the future. But after 3 years now, I can tell you that we had very nice situations, very nice cases, as you can see. Most of them were, let's say, fitted to my minimally invasive approach that I do in my everyday practice. And now I would just like to remember, as you did yourself, Ronnie, I would like to remember about the first matrix case, and that morning that we had this patient coming to our office for an immediate implant placement in an upper premolar. He already had classical tissue levels and a bridge for more than 6 years in sight. And we did preoperatory scanning. And we did it for creating the surgical guide and also for having the exact design of the extracted tooth to use it afterwards. So we used our usual protocol of a flapless approach in these scenarios. At that time, we only had initial drilling protocol from TRI. Now we are hoping to have the full digital guide very soon. And this was, of course, the first contact with the real toy. The one that you saw before in Sandro's office was, I think, 20 times bigger. So going back to the patient, we inserted the implant. And for the gap, we used our described protocol as we use usually the open healing protocol. And I have a short movie about this. So it was just a minimally invasive extraction. And then we went with a surgical guide. The initial drilling. the implant. The implant was placed freehand, of course. We double checked the torque by hand, and now we have to fill the gap with BIOS, our protocol. For the moment, we had that stock healing abutment on site that we kept to avoid having the granules in the implant. And now, before placing the membrane, we scan. Immediately after the scan was done, we finished with the surgery, but meanwhile, the files went away to the computer, such as we can produce a copy of the tooth, and we use it as a special customized abutment. This is a CBCT immediately after the surgery, and the same protocol that you saw. The only difference was that we did not load it. We just use it as a personalized healing abutment because of the parafunctions of this particular patient, and I did not want to have it loaded. So we just overlapped, and we had the final customized healing abutment with the same emergency profile. And this is how the soft tissue looked. And again, as mentioned before, without any other necessity of disturbing the patient, we used, after 3 months, we used the scans, and we replicated the final crown. The thing that I like very much about this system is that you will see now the emergency profile of the crown. It's very, very much similar to a natural dentition situation. You can see it. And here is the final crown, respecting the biological width with a tissue level implant. And the X-ray. Now, after 1 year, we have a CBCT scan, and this patient was part of our observational study. We compared 50 TRI matrix implants and 50 TRI octa implants, and the objective was to measure the bone levels. And we were very happy to see that we had a slight difference as an advantage for the matrix. You can see the red line with the matrix. And now 3 years for the matrix and 9 years for the TRI octa, and the patient is 80 years old. So he had the benefit of this minimally invasive approach, and you can see the marginal bone levels. And now talking about the TRI octa, 9 years, we also had a clinical study with this, and I'm going to present it later today on stage in Bucharest with Professor Buzer in our ITI study club in Bucharest. And we had very good details with this too. So the final message is, whenever possible, be minimally invasive, and the matrix tissue level implant was used in our office in the last 3 years for high aesthetic outcomes and patient comfort. Thank you very much. Keep it simple, think biologically.
Thank you so much, Alexander. It's a very nice presentation, and I think what really makes it unique is that you have also the comparison now to this 9-year result with the standard soft tissue level octa implant. How do you explain that the performance now on the matrix is even better than the standard conventional tissue level implant? Where do you think? Because from the connection point of view, they might be not that different. We have similar distances to the biologic wish. How can you explain that the matrix even performs better than the conventional one?
I think that this particular situation is connected somehow to the less tension that it's generated because of the concave design of the transmucosal part, and also for the fact that we basically do not have any other kind of bacterial infiltration, and no other risk of micro gaps that we have when we cement and especially when we have the titanium base, where there are two types of connections, one between the implant and the titanium base, and one between the titanium base and the crown.
That's an excellent question, because I think you really address it very clearly. It is never anything what happens regarding the modular bone is not a one parameter thing. These are multiple parameters which play a role there. I think we will never be able to really just say one is more dominant than the other. But I think you brought up some important points. I think having no cement gap from a titanium base, I think it's definitely an issue. And also the concave form of the tissue part, which gives more space to the soft tissue, which also gives then a more stability to the bone, might also be an issue. So I think these are multiple issues. As you said very clearly, that's never something which is just one parameter. But it's good to see that it works in this area. Today, when you need to make a decision between taking a matrix or a standard implant, tissue level implant, are you have any preferences of one or the other, or do you say today I primarily use the matrix implant? Or what is your indication for using a conventional soft tissue level implant?
Lately, I decided to use more matrix implants in the aesthetic zone, because I control easier compared to the conventional, considering that I'm only using tissue level implants in my everyday life in the office.
Excellent. Thank you very much for sharing this experience and these exciting results. It's very nice.
Thank you very much.
We are very happy to move on to Andrea Anini. Andrea was also with his brother there at the special event. I remember that very well. And Andrea, he graduated 2007 from the University of Modena in Italy. He is the author of the quintessence book, Digital Dental Revolution. So he's very familiar with the topic about digital dentistry. He's the founder of Digital Dental Revolution Education, and he works in a private practice with his brother Alessandro in Italy. So, Andrea, we are very excited, and would like to thank you very much for sharing your experience with the TRI implant.
Thanks, Ronan, for the kind introduction, and thanks, of course, TRI for the invitation. And yeah, since we have like 7 minutes, just start immediately and deep dive into the topic, which is we like to see the big picture. We like to discuss about the digital implant revolution. And because we really think that right now we are living in a revolutionary era, and any concept that nowadays is defined a revolution basically should improve the quality of the restoration that we were doing in the previous way, should like enhance positively the time and the cost for us and for the patient, and of course should improve the quality of the life of our patient. And so there is no doubt, sorry about that, there is no doubt that digital dentistry had a great impact on these four concepts that I just explained, thanks to the introduction of the intraoral scanners technology, but also thanks to the evolution that the materials had over the years. And nowadays we are going more and more in utilizing monolithic materials. And we like to call it monolithic technologies because it enhances the efficiency of our overall digital workflow. And basically, we can say that dentistry right now is living an era in where we are trying to reduce interfaces. And I see a big similarity between the evolution of the monolithic zirconia, for example, with the matrix, with the TRI matrix, because we think that really has been a revolution in reducing interfaces, because the traditional key points of the digital implant workflow were 7 key points, in where we had also to deal with tie bases, we have to deal with cementation. If we were in the aesthetic zone and we didn't want to use monolithic, we also have to deal with a master model. But thanks to the concept that the matrix brought into the ball game, we were able to reduce from 7 down to 4 steps the overall workflow. And so that's exactly what we were looking at, trying to reduce passages, because technologies and digital dentistry is all about reducing passages. And if we are able to reduce further passages, which means increasing the accuracy, then we are really on top of the game. And what we really like, besides the concept, is the design of this tissue level implant, and so we like to call it tissue level experience. And like every time we say that, of course, every tools is great to add into the digital workflow, but we always need to rely on the traditional fundamentals of dentistry, which are still guiding the treatment plan decision making, and they're still guiding us how to formulate the diagnosis and then how to strategically sequence treatment planning. Because here I'm showing you a case in where we had like this 82 years old lady, in where we have utilized like a tissue level implant on one side and a bone level implant on the contralateral side. And we utilize the tissue level implant where we like the most, so in a perio-cross rehabilitation, in where you see here we had this lady that we needed to do like a resectomy in order to maintain her molar, and we had this eyelid ridge in where we placed in a flapless approach a tissue level implant. Here you see a magnification of the surgical field, in where like you see, of course, the osteotomy and was done freehand. Nowadays, thanks to like 2D evolution that Matrix is having, we are also able to do like in a guided surgery fashion. And here you see once again some snapshot of the surgery, and you see here how we were able to place properly in the 3 dimension of the socket of the eyelid ridge, the implant. And so implant is always prosthetically guided. So once again, here is not digital dentistry, it's about like our traditional knowledge in where the implant should be placed according to the fact that you are also utilizing a tissue level implant. So this will guide us also by having like a 1.8 collar neck. We have to know that this is going to be like a sort of a portion of the emergence profile of our provisional restoration that then will become a final restoration. On the contralateral side, same approach, perio-pros approach. In this case, we utilized a bone level matrix. The concept didn't change. It's very important in every single step. Careful details should be always like re-evaluated during the surgery. And here you see some of snapshots of the bone level matrix, which is going into the place. And here you have like the healing phase, which we waited like 4 to 6 months. In this case, with of course provisional restoration in place. And at this point, provisional restoration on the natural dentition, not on the implant. And at this point, we were able to start the digital implant workflow. And you see here, like in this case with iTero technology, we are able to utilize the scan body. We are able to detect like easily the vertical finishing line preparation for these abutments, both on the right and on the left side. Here you see like the big picture of like the digital scan protocol that we have utilized. Of course, the provisional restoration plays a pivotal role because it's our prototype for the final restoration. You see that we have like a couple of abutments also in the lower arch. So we have like the provisional restoration scan first, then the lower abutment the lower provisional restoration scan, the bite registration, as well the scan body scan, and of course the lower abutment scans. We send everything to the lab, and we have to give like a big thanks for Pier Francesco Gorfarelli, since moment one worked with us in like also updating the libraries of the 3D touch scan body from Matrix. Here you see the moment of the best fit, in where is indicating like 3 common points for the also the scan body library. And here we have like a sort of quality control. So why technology is very important to us, because give us the opportunity to do like a quality control in every single step of our workflow. Then once he decided that our impression was good, is starting like to work on the final design of the restoration. And of course, his traditional knowledge blended with the digital possibilities are extremely important, because he has to create like also the specific form of the root rhizectomy as the crown. And here you see our implant as well, which is ready to be milled. Here you see some final aesthetic characterization. You see, of course, also the nice and smoothness of the matrix connection. And of course, by doing this protocol, we are able to improve the aesthetic, because you will see also the healing of the soft tissue are incredible. And having the opportunity to avoid T-base, like you were saying in the discussion a few moments ago, it's very important, because we don't want to deal with the cement. We don't want even to deal like with the passages. Each passage, even if it is done by the best lab technician in the world or a best clinician in the world, might have mistakes. We will have mistakes, even a minor mistake, but it will have mistakes. So if we reduce passages, we reduce mistakes. We improve the quality, we simplify our workflow, and we are saving time and materials. And this is the day of the cementation of this, one of the very first case that we have done. You see the situation of the day of the cementation, and here you see the 3 years follow-up on both sides. Everything is very stable, and the patient is absolutely extremely happy, and periodontal health is there. Of course, we need to also create like a strict follow-ups in terms of hygiene maintenance, but that's absolutely what you all guys know. Nowadays, we have also the opportunity to even speed up more this thing, because we have the implant scan print workflow. I mean, that's not my topic of today, but like Professor Young was showing, 1 hour after the surgery with the 3D printed technologies, really we can absolutely increase the efficiency. And what does it mean concretely, increasing the efficiency? This is the digital return on investment that we had. And we had like a report analysis data in the last 5 years of our digitalization. And you see that basically we were able, thanks to the technology, to reduce the number of appointments on average for implant restoration from 8 to 6 down to 4.9. So it's almost 50%. Similar thing on natural dentition. So we have less appointments, but what is incredible is that these appointments are even shorter. So we are like not only reducing the appointment, but also the treatment timing of procedure are reduced by 45% of our time. So this is incredibly efficient. And so take a message, absolutely, we should incorporate this technology, because it gives us the opportunity to reduce even more interfaces. We don't have T-base anymore. Thanks to the monolithic technology, we don't have the ceramic, which was the layered ceramic, especially in the posterior area, which was another interface. And so we are going to reduce more and more the interfaces. We're going to reduce more and more the passages. And so we can absolutely say that the future is now, because we are we are living in an era that if we know which kind of tools having in our box tools, we can be extremely efficient. And so I'm done with my presentation. As Sandro asked me, just want like to invite all of you to see more, to deep dive more into this concept, the 17th and the 18th of November in our facility. But not only for that, actually, you should not come for us, you should come for the Ferrari experience that I bring you all over in those 2 days. So thank you very much for the invitation once again.
Excellent. Thank you so much, Andrea, for this very nice presentation. I love looking at these also comprehensive cases, including the period situation. And I think you mentioned 2 things which are really important for me. On the one hand, I like the statistics about the visits, because that's something which you usually don't see in research. But on the other hand, you said something very important. It's not just about gaining time. It's also about reducing the steps. And each reduced step increases the fact that we do less mistakes. And I think that's a very important message. So thank you very much, Andrea and the team, for these very nice results. And we move on in order to stay with time. Now I would like to invite Ivan Pev for his presentation. Ivan is an extremely experienced implantologist. He graduated 2011 from the Medical University in Varna in Bulgaria. He's the chief implantologist and innovative director of Dentaprime, the biggest European implant clinic. And he places more than 20,000 implants. And we are really excited, Ivan, to get a little bit more to know how was your experience over the last few years with the matrix implant.
Thank you very much, Marnie, for the kind introduction, and thank you very much for inviting me here. I feel really honored to be here with you. So, the matrix cases are really exciting. Actually, I will introduce a little bit my clinic. This is our main building of the Dental Prime Clinic, which I'm representing here today. We are inserting 1,000 of implants each year in order to help thousands of people each year. We are working mainly in the field of total mouth rehabilitation with fixed bridges construction over Oron5, Oron6. Thanks to the fully digitalized workflow, we're able to achieve very good efficiency, and we are able to offer for our patients affordable prices. And the matrix implant is also a big part of our success. This is it, the bone level implant, which we're using at the time. Thanks to all the great team of TRI, we had this possibility to collect ultimate experience by inserting 30 implants for 2 days. On the different cases, single crowns, bridges, and the all on matrix case, the first case with angulated matrix implants. This is our clinical case. The patient, approximately good health condition. He has blood pressure well controlled by medications and some bad habits with consuming of alcohol, and he is a strong smoker. So the situation and the anatomical part with totally edentulous upper and partly edentulous lower jaw, it was enough bone for implantation. I prepared a drill guide for the upper jaw, and this was at the time our workflow with digitalizing this wax rim in the mouth before the operation. This is the physical drill guide and the wax rim. I was looking at from the occlusal side of view, and the older version which we're using in the past for analog impression. So situation itself, very bad hygiene, as you can see, the fixation of the drill guide, the drilling process. I used here a simple drill guide only for the twist drill, which is giving us exactly the position, the depth, and the direction of the implant. So I opened the flap only because I should do also some bone augmentation to support the bone. Otherwise, during the implantation with the matrix, it's very easy when you use for angulated implantation not to be very careful where exactly the inner part of the hexagon is, because it is not hexagon. It's not depending for the position after that. This is the bone graft during after the implantation, and we used at the time this prefabricated healing caps. Now we have much better solution with the healing caps, which is individualized. The angulated position, approximately 30 degrees in the lower jaw, also conventional way of operation, nothing amazing, standard closing, and the using of the scan bodies. Nowadays, this scan bodies is much easier to be used thanks to the scan bridge, because it was here a difficult situation with small deviation, sometimes on the lower jaw. Now it's avoided thanks to the scan bridges. This is the image and the part of the colleagues which they do on the in the lab. They align the position of the scan bodies into the oral scan in order to transferring the connections and to the position of the implants, and they're creating the provisional constructions and for the upper and the lower jaw, and shaping the emergency profile, which is given after that, forming the soft tissue after the insertion of the primer construction. So here is also the provisional construction, CAD-CAMmed PMMA for the upper jaw. It was ready in 2 hours, so we tried out into the mouth, the check-in, the movements, the blockage, the group guiding, everything was fine. So patient directly after the insertion, and the X-ray immediately after the operation. Fixed constructions, fully zirconia framework. If we look a little bit closer, you will see that we have extreme long cantilevers, but it's working. So 14 millimeter, 12 millimeter, also 3 bridge bodies between each other without any fracture area. Of course, 3 years after, without bone loss, without any recession. You can clearly see the stents of nicotine that this guy is using a lot, but even through this, we don't have any problems with the pink aesthetic, or the level of the soft tissue. Any inflammation is avoided. So this is the result. 3 years after, the guy is very happy and enjoying his life. And the team behind the success, thanks to the TRI, and we solved a lot of issues during 3 years. We changed the size of the screw, the design of the head of the screw, the width of the channel, the screw channel. We managed the passive fitting with verification jig. We minimize the deviation from the scanner using these scan bodies, the individual healing caps, a lot of things that I'm very proud to be part of this. Thank you. Thank you for your attention.
Thank you very much, Ivan, for this impressive presentation. I think you have been really the pioneer when it comes to these larger edentulous cases. Now we saw some implant issues, but that's kind of what can happen when you're really going in these areas of clinical treatment. What I'm interested in, because what is really new regarding the matrix is primarily the prosthetic and the interface there. Have you seen now with these large reconstructions any issues regarding then prosthetic failures on the matrix implant with the new connection?
Actually, at the beginning, we had some issues, which we solved the problematic, because when you scan the full mouth with the scanner, there, in some cases, there are small deviations, and we was able to achieve better success with forgivable connection in one part, and the second part was the scan bridge, is very helpful for full mouth scanning. Now we don't have any problematic issues.
So today you feel confident also for these larger bridges to go with the matrix implant and a full ceramic reconstruction?
Of course, definitely.
Excellent. Thank you very much, Ivan, for sharing this knowledge. And I'm very excited and thrilled to introduce Marco Zeltner. Marco is a good friend of mine. He graduated from the University of Zurich. He was a postgraduate student at our clinic. He is still a faculty of the clinic, and he works in a very successful, very famous practice together with Andreas Grimm, also former faculty of our clinic. And Marco, we are now really excited to share with you the anniversary, the 3-year anniversary for your matrix cases. Marco, stage is yours. You need first to unmute.
Now you can hear me?
We can hear you perfectly.
Very good. Thank you, Ronnie, for the kind introduction. About 3 years ago, a new player in implant dentistry was introduced to the market, which was said to change, in particular, implant-supported prosthetics. No abutment, they said, no cement, no limits, and that was the company's slogan for the new matrix system. That convinced myself to be part of the early market release in 2020, and also the matrix, especially when matrix was presented to a worldwide audience for the very first time. And I remember very well that at that time, and I used exactly the same slide as you can see here, I said that I'm a happy dentist who is open to something new. And I also said that I believe in it very enthusiastically if I'm convinced that there is an added value for the patient or the practitioner. And now, looking back at the last 3 years, the matrix implant has not disappointed me. It's quite the opposite. And this is why I'm very happy to be here. So from a biomechanical point of view, the reconstructions, they work with stable connections. As the other said, we are almost completely free in the design of the prosthetic emergence profile. We use a highly biocompatible material with polished zirconia in the transition zone without any cement gap. And we have reported very high survival rates. And all of this at a very fair price, I would say, and a very simple workflow. So as I said, this is why I'm so happy to be again invited speaker at this 3 years anniversary. And I would like to give you in the next 5 minutes a short outline of how the use of matrix evolved in our Swiss private practice from single crown to immediate digitally fabricated full arches. And of course, as you others showed the first cases too, I would like to show my very first case too, to talk about the evolution we had with matrix. So this patient came to our clinic and she was in pain due to a vertical root fracture that had split tooth number 25 in two. So radiographically, you see a huge tooth, I would say, with a very long root. And because we were also aware of the good properties of the TRI implants with regard to primary stability, we decided to place an immediate implant in this case. So the tooth was extracted, an immediate matrix implant was placed. The socket was filled with a xenograft and covered with the resorbable membrane since, as you can see, a quite narrow standard healing abutment was used at that time. So at this time, we placed the bone level matrix implant. Here you can see the according X-ray and also the healing after 10 days when the suture was removed. And here is the patient 3 months later. She came back and an intraoral scan was performed, similar to the cases you have seen before. And the data set was sent to our lab. And then our technician subsequently designed a monolithic crown, which was milled out of a zirconia block and finally sintered. And please note that at this time, our technician always used the printed model to control the fit of the crown. Here's the clinical situation right after delivery of the crown with a visible zone of anemia, as you can see, due to the pressure of the crown when we have inserted it. And here, the clinical situation 3 years down the road with the according X-ray tool. Please see how nicely the soft tissues improved over time. And here is the final result. I would say happy patient, happy doctor, but to be honest, nothing special really. So the matrix crown in this case was produced with a similar workflow we have used for any other implant brands. And we knew at this time that we had to make better use of the features related to the digital workflow. And we have noticed in our clinic that this works very well, at least in our setup, as I said, with the matrix tissue level implants, so which we use as hybrid implants for all our cases nowadays. So no bone level matrix implants anymore. So what's next? I would like to show you this case. The next step forward was that we started scanning the position of the implant already in the surgery. So this enabled us to print or mill perfectly individualized healing abutments or even temporary crowns, as you guys seen before, depending on the primary stability, of course, with very little effort. And even an individualized healing abutment, and especially a temporary crown, is a huge benefit for the patient. Because, for example, the insertion of the final crown is going to be super comfortable, as of course no excessive pressure is exerted on the mucosa, as it is usually the case when changing a standard healing cap to a crown with a much larger diameter. And look again at the follow-up picture. So you see the initial situation on your left-hand side, the final crown after delivery in the middle, and the 3 years follow-up. And I think it's really amazing how the soft tissues develop over time, due to the features of matrix crowns in terms of biocompatibility, I think, because of the biocompatibility and tissue integration of polished zirconia in the transition zone. And we observe this in many of our cases. So at this moment with the matrix, we were able to take a step towards personalized prosthetics already at the time of implant placement. But in our clinic, we haven't reached the end of our evolution. We wanted to make the whole thing even more attractive for our patients, and that included also cost efficiency. So for patients like this elderly gentleman, we decided to produce the definitive crowns within a few days, and I'm talking about 2 or 3 days here. So here you can see 2 completely digitally fabricated splinter crowns to replace 2 premolars in the first quadrant after delivery, and 2 in the 2 years follow-up. And this only with placing the implant, scanning, designing, milling, sintering, without the use of any physical model. And we started with some smaller cases like this one. So immediate implants to replace 3 failing teeth in the upper left jaw. The patient shows up with teeth. We place the implants, and the patient leaves the clinic with a fixed 3D printed temporary 3-unit bridge. And here are the according X-rays, and I'm really impressed always about the perfect fit of these temporary bridges. And of course, this was only an intermediate step towards a very cost-efficient, completely digitally planned immediate full arch case. And I would like to show you this case now. So after diagnostics with the virtual setup, you see the initial situation in the upper row, and we moved on, and we asked our designer to transfer this to the CBCT scan. The implants were planned, and the information then is transferred into the mouth by means of a surgical guide. Here you can see the pictures, initial situation on your left-hand side, the surgical guide in the 3rd row, and the situation after implant placement. And this was this was a placement in a very efficient way. And then the position of the implants can be captured by an intraoral scan in a super easy way again. Thanks to these 3D printed scan bridges, we are very simply connectable to the scanning post. The whole data set is subsequently forwarded to a lab where a talented designer is able to merge the original setup with a scan of the implants. The rest of the job then is done by a 3D printer. And a few hours after the surgery, the patient actually goes home with temporary fixed teeth, which we can basically use as another diagnostic tool. And these temporary bridges can be modified before the fabrication of the final crown. And this is really a very cool workflow. And as I said, I'm very excited how precisely the 3D printed multi-unit bridges they fit. So to conclude, in our clinic, we have to say that the matrix implant has become an all-rounder implant. I'm sorry, now I cannot see my presentation anymore. In our clinic, the matrix implant evolved, also thanks to the digital workflow, to an all-rounder implant I can use for many clinical situations, even for implant-borne removable prosthodontics. So my colleague Marina Siegenthaler from our clinic, she is now doing some removable cases with titanium bars, and this in a very efficient way. And as I said, I'm fascinated about the implementation of personalized prosthetics already at the time of implant placement, the option of immediate implant placement and especially immediate loading. And this, as I said, all at a very fair price for our patients. So thank you very much for having me again at this 3 years anniversary. I think you can see that I'm very excited that I'm able to work with this cool implant, the matrix implant.
Thank you very much, Marco, for showing your own evolution, not just the evolution of the implant. I think you really nicely showed how you gained confidence over the years, starting with kind of really more conservative protocols in a heel bridge, place the implants, going to immediate implant placement, and then at the end, immediate temporization of full arch cases. So congratulations, Marco, for this nice evolution. Now, I would like to conclude with the last speaker, with Joel Teles. He's graduated in Porto, at the University in Porto in 2005. He's a renowned expert and speaker for immediate full arch reconstructions. And since 2005, he's the clinic director of the Modiduro Clinic in Portugal. And personally, I have received from Joel different nice cases. So I know he's really an excellent clinician. And I'm very happy and proud to have you been part of the board. And I would like to welcome you being now on stage and sharing your experience over the last 3 years. Joel, you also need to unmute. Joel, you need to go one more back.
Now you can listen to me.
Yes, perfect.
Okay, thank you for having me and for your kind introduction. Let me go full screen. So yeah, the matrix for me started like 5 years ago with a conversation between me, Olga, and Sandro. And the thing that immediately struck me is that it was a certain thing that our restorative materials keep evolving, and we as surgeons were stuck with the same connection. And it came to me and as a realization at that moment that, yeah, type basis was something that was created to solve this mismatch in between worlds. So it was the middle guy and the guy that came as a solution, but it was always a compromise in our practice. And immediately I was stuck in the idea of having an implant that would allow us to avoid this middle guy, to avoid this compromise that we were having with tie bases. So it was from the very beginning something that I was very interested in. But I will share with you again the first case I ever made with Matrix. It was a molar site. I presented this in our event in 2021. And I didn't want to change everything at once, so I kept every of my protocol the same, changing only the implant. So you can see that here that the tissue was already very collapsed, not that much keratinized tissue, and very thin tissue as well. So I performed like I was used to. I placed the implant, choosing the right depth, and I made an individualized healing cap. I really don't like using, I never did like using standard healing abutments. I normally individualize all my cases, or the majority of them. And so I did the same here, using titanium abutment, the only abutment that you can buy from TRI to use Matrix. And the result after a single surgery and after 2 months was that. The beauty of it is that once we start working, the final restoration, immediately I could see the benefits, because no longer we need to select a tie basis. So we can go one-to-one with the profile that we have created. And that for me was already a big thing. So now I don't need to have the discussion with my lab, which height of tie bases we are going to select. And the width is always the same. And we start compromising with what I have created during the surgery, thinking what I was aiming for that patient, for that situation. So immediately I could see the benefits. And this is the final restoration after 3 months. And it was absolutely amazing. Stable bone, and the scenario right in the placement day was for me very good. So I could immediately see what benefits Matrix could cause to my clinic. But of course, I was still using what I was used to do, individualizing by hand my healing abutment. So the next thought was, okay, so now I have this tool, which is way more interesting than what I was used to do. What if we can arrange something else? So TRI offered us these pre-made different shapes and different heights of healing abutments that we can print and that we can use. And it goes with the same purpose, like a cervical, but done previously. You just need to polish it. You open your surgery and you hold it in place and you retain it. It's not indexed, so you just select the right positioning from that tablet that you see there on the upper left side, and you screw retain it. And that allows you to create these profiles in a very easy, very cost-efficient way, and with amazing results nevertheless. So you can see that by doing so, you individualize all your profiles. You can see in the image that I didn't individualize the last molar on the upper left image, and you can see the difference it makes. You can really create beautiful emergence profiles by using this instead of what I was doing. And taking it a step forward, you can also do that by individualizing small bridges or crowns or whatever. You just place your implants, you do an intraoral scanner, and you ask for your lab to send you in a few hours' time a bridge, a crown, whatever the situation asks for. You suture on top of it, and you wait. And the beautiful thing is that if you are happy with the result and your patient is happy with the result, in the end, you just need to call your lab and say, okay, just mill me the final one in zirconia, and you just retain it. So it's very, like all my colleagues said, it's very time efficient, it's very cost efficient, because you don't no longer need to have so many steps, adding mistakes and selecting cementation lines, because we all say that we don't do cemented restorations, we do screw retained restoration. But in fact, we were doing screw cemented retained restorations. So the cementation line was still there, but not anymore. And if you think, it's all about this beautiful macro geometry and this very smart connection. So it's very easy to control the implant depth with this beautiful multi-level implant. The concave emergence profile is beautiful, and you'll see a little bit further why. The anodized polished neck is amazing for bone. We were thinking in the beginning and calling this tissue level because we're thinking about tissue, but for bone actually. The freedom on designing of the correct immersion profile, mimicking one-to-one what you have created during the surgery, and no cement, no abutment. So if you think about this classification from MEDA, in the obviously you can see the correlation between this and the one classification. If you think about this, the matrix as the first part done for you. So you just need to focus on the rest of it. It's already starting well, and it's very forgiving because you can play with this, doing the right inputs for tissue. And this macro geometry for me is part of what makes this implant so special. And of course, the lack of the need to use a tie base on top of this that would ruin this experience, this flawless experience that you are aiming when creating an emergence profile. So I presented this case back then as well. And if you look at this, probably most of us, me included, while looking to a case like this, we will immediately start thinking about bone grafting, tissue grafting, all these things combined in the recipe. But I did something very simple here. I just made a simple modified roll flap and a bit of approach at the 11. And you can see the results with PMMA restorations after 5 weeks time. And we can see the real benefit of this absolute freedom on the designing of the profiles. And so after 3 years, this case is now 3 years, and you can see the results that we've got with this amazing implant, this multi-level implant. You can see that all these things combined, the correlation in between the very forgiveness that you have on the depth control of this implant, the right inputs for tissue that you no longer have steps in between, just one connection, very precise, and the designing of all of this contribute to the what you are aiming for, be time efficient, cost efficient, and mimic nature. And that's the beauty of this matrix system. And I think that in this case, it's very well illustrated. And if you take this to an extreme, and I always like to go back to this case, when we're talking about lower incisors, it's always tricky because there are very, very small teeth. And if you think about a tie base, normally they always have the same width. So you end up compressing tissue because then you have the cementation line and the zirconia frame on top of that. So it's a lot of variables that you need to consider in a very small space. So as the space gets smaller, the bigger problems you might encounter. And if you look at this case, I don't see another system where you can make a crown and mill a crown like that over an implant reconstruction. I really don't see any other system that can do this, and that you can offer to a patient with a situation such as this, a scenario such as this, after 2.5 years control picture. You see there the screw channel, because back then we didn't have angled screw channels, but nowadays, if this case was done now, I could angulate it, and so the screw channel will be on the lingual part and not there, as you can get to see. And look at bone stability after 2.5 years. Look at bone stability. That's, again, the beauty of Matrix. And in these case scenarios, I really don't see any other system that there's so much to offer to you. Regarding full arch cases, this is, again, the first full arch case I have made with Matrix. It was all planned via software. The surgery was guided, as you get to see here, and we were doing the pickup technique with the same titanium abutment. The only abutment here I will sell it for Matrix implants. The result after 4 months waiting time, and you can see the bone stability of this Matrix implant in full arch reconstructions. In the end, if you are pleased with the result, you just call your lab and change the prosthetics for the final ones, monolithic reconstructions. Again, it's so easy to do with intraoral scanners, and now with the scan bridge, it's so easy to do. And after 2.5 years, look at bone stability. No problem whatsoever with the reconstructions, fully zirconia reconstructions. No problems with bone quality. The tissues look amazing. It's really, really interesting. And if you think about FP1s, this gets even more interesting. Like in this case you see here, because in FP1s now the freedom is even better than before. Because when I was doing FP1s with standard, with using multi-unit abutments, then I have the connection in between the implant and the multi-unit. Then the multi-units always have the same width. We all know that we should avoid lateral positioning of the implants, because then the width is too much on the multi-unit and it's compressed and the papilla goes away. That's why you often see doctors placing multi-units on the posterior regions and going straight to the implant on the anterior regions. I honestly don't like that. I think from a passivity perspective, it's very difficult to achieve a very nice fit. And with Matrix, it all becomes a breeze. And the best part is that if you plan everything right and you're happy with the aesthetics of your case, even in angled implants like you see there on the 26, you're happy with the tissue result after 3 months, you call your lab and you say, just send me the final restoration. Keep the aesthetic, just changes to zirconia, screw retain it, and that's it. And this insertion, even with angled implants, is a breeze. And that for me was what I was still hoping to see what would happen while placing angled implants, and the way it would fit. It's amazing. It's amazing. So I really think that with the Matrix, we now have a bulletproof implant and a future-proof implant. And the bulletproof implant is because it's all-rounded. I don't see a situation or a scenario where this implant makes less sense, or it's less adequate, or would not be my first choice. And the future-proof is because now is the materials and the machines that need to evolve, because the implant and its connection is absolutely future-proof. So the implant, as surgeons, we are ready. So let the materials keep evolving, let the zirconia keep evolving, let the 3D printers keep evolving, and we are ready for them. And this is something that TRI customers can say that I really don't think any other system has to offer. So thank you for having me. I hope I didn't take too much time. And back to you, Ronnie.
Thank you very much, Joel, for your energetic and nice presentation, also showing really a large variety of different cases. I come to the conclusion. I think we have learned 4 things. Number 1, I think the enthusiasm and the passion for the implant after 3 years is at least as high as 3 years ago, or even stronger when I look into your eyes. Number 2, I think we see really benefit on the level of biology, on the level of the hard and soft tissue interface. Number 3, we see benefits on the level of the prosthetic reconstruction. And number 4, we do also see benefits on the level of the economic situation to really reduce steps, as Andrea showed, and reduce the time needed to spend at the patient side. With this, I think we keep our spirit and our enthusiasm for that. I'm looking forward maybe to the 5-year follow-up of all of us. And I would like to thank all the attendees for sharing or for taking the time to share this with us. And a great afternoon, and thank you very much. Bye-bye. See you soon.